This is about X-ray. X-ray and orthopedic surgeons are absolutely two sides of the coin. They can't exist without each other. So if we take X-ray, then we must know how to position it. It is, after all, a matter of controlling the shadows. Anybody who has done photography with flash knows how difficult it is to control the shadow of the flash. It can make or break a photograph. Similarly, positioning the patient and then taking the X-ray is the gist of everything that we do under exercise. In all examinations of the any joint, we need X-rays at 90 degrees to each other. Two X-rays are essential, and they should be at 90 degrees to each other so that you get the complete view, orthogonal view. Now, in shoulder is such a joint that it's difficult to go around. And starting with the AP picture, usual tendency is to make the patient stand and then take an X-ray, forgetting that the X-ray, the shoulder is not parallel to the uh, plate, but it is at an angle. As a result, what we see is that there is an overlap. The glenoid shadow and the humeral head shadow overlaps. So this is not a true AP picture. This is an oblique picture. What we say as a AP picture is really an oblique picture of the shoulder joint, because the shoulder joint itself is at an angle, and that angle happens to be about 35 to 45 degrees. So what is the true anterior-posterior view of the shoulder? For that, we have to tilt either the patient or the film or the X-ray machine so that we get at the line of angle of
Yeah,
the
but same to same pustaka.
the true anterior-posterior view of the shoulder,
इथे करायचं का?
also mentioned as Gresham's projection. Gresham was the one who instituted this, and it is also goes by his eponym, Gresham. What we do is to keep the patient at an angle of 35 to 45 degrees. This is the film, and this is the axis of the patient. So with the result, when the beam comes in straight, you get that joint. And the beam is also tilted 30 degrees, not 100. It's 30 degrees tilt and 35 to 45 degrees at an angle. That works best. The conventional AP, as we all know, we keep the patient parallel to the plate. So the joint is at an angle to the plate. Here we are. The conventional, the red arrow will show us overlap, while the green arrow, which is the true AP, will show us two joint surfaces separately and parallel to each other. So whatever we did is judging roughly 35 to 45 degrees. Now, if we want to be absolutely correct, precise, every time we repeat it, there is another method. This method is depends on the body structures. The tip of the coracoid process can easily be palpated, and the posterior edge of the acromion can also be easily palpated. So one draws a line uh, between these 2 points, and that is we call it as axis. Then we shift the patient in such a way that this axis is right angle to the plate. X-ray film. You can see a marker here. It is right angle we are already given, and the patient is like this. So we make it at right angle to the plate, and then we take an X-ray. That will be the perfect lateral. In the bottom row, you can see the red arrow shows an X-ray which is done by tilting the patient to 35 to 40 degrees, while the picture D shows one which is done with the marking the fulcrum line, that is connecting the anterior coracoid process and posteriorly the tip of the acromion. We connect that line and bring that line at right angles to the plate, then we get a perfect X-ray. So perfection is what we need. So there we are, an enlarged portion. You can see clearly here there is still a little degree of overlap because it's a judgmental. We just turn and twist. Here we are precise, accurate, and that's why we get the best result. we achieve excellence through pursuit of perfection. Uh, it's not unusual that this paper came from Germany. German people are known to go for perfection, and they found out a method how it can be done. Now, when you take a true AP, it is easy to diagnose when there is an overlap of the two articular surface. You can. This is the normal one. This is a dislocated one. This is the anterior dislocation of the shoulder. This is pseudo dislocation because there is a fracture here, and that is called hemarthrosis. So it has caused downward displacement because of the hemarthrosis and giving us a picture of a pseudo dislocation, which can also be seen in this way. This is only indicative that there is some fluid inside which is pushing the joint down. Posterior dislocation of shoulder is one which is often missed and is common in 50 years and old. And the true dislocation, a true APV is very useful. We'll see a little later how it is done. Another way taking a lateral picture of the shoulder joint is to take an axial view. You make the patient lie down and beam it through the axilla, and you get a perfect picture. This is fine if the patient has a full painless abduction. This X-ray can be taken very easily. However, in fracture or in other conditions where patient cannot abduct, it is very difficult. It's difficult for the patient to lie down on X-ray couch. It's difficult to abduct. Hence, axillary view is a painful. Certainly, in fracture, it is extremely painful. But there is another way of taking a perfect lateral. There is no need to lie on the table. No need to abduct the shoulder. And the view we call it as a Y lateral. Now, how to get that Y lateral is to place the patient along the long axis of the scapula. Then we get the perfect lateral. Here we are. This we have marked out the spine of the scapula, and this is the vertebral border. These two, and now we have positioned this dotted line at right angles to the shoulder, to the X-ray film, and then take an X-ray, the caudal 10 degrees, and we'll get a perfect lateral. We get something like this, and one need to see where is what. So if we trace the lines, then we have something like this, which is the coracoid process anteriorly, and then we continue tracing that line, and then we have the acromion. So we have something there. After that, we try and locate where is the glenoid. Here it is, and then the body. So once you know what silhouette to follow, it is so easy to find out where is what. Once you locate the point to scapula, head of the human, it also resembles a Y. As you can see, this thing very much resembles this Y. And now you can imagine why it is called Y. And one can now trace the head of the humerus, which is lying posteriorly. It is not articulating in the surface. Once you have taken a lateral picture with the Y lateral, you can locate the head of the humerus. It's posterior, it is dislocated one. So Y lateral. In this picture, it is perfectly looking like a Y. So there we are. This is the way to take it 10 degrees and the marker of the scapular joint, and you can do that. This is a Y lateral which is showing a dislocated shoulder, and this is the picture which was taken after reduction, and now you can see it is in position. This is the Y, and the head is anteriorly lying like this, while after reduction, this is the Y, and the head is right in the center of that Y. So without much trouble to the patient, we can judge and get position. There is no need for CT or MRI in such cases. I'm sharing a true story. A woman in late 50s was riding a scooter. She was pillion and she fell down. She had some discomfort in the shoulder and was unable to use the arm. Luckily, she fell down in front of a large hospital in western suburbs of Bombay. So immediately she went to the casualty. Casualty officer asked for an X-ray, which looks something like this. I said, "It's fine, nothing. You give your sling and then go home." She was asked to come to the fracture clinic, and there probably some junior doctors saw and same X-ray, but slightly better position. And they said, "Okay, nothing. Go for physiotherapy. Come back after 2 weeks, 2 months. You will be fine." After 2 months, I think the consultant saw her and then realized that this has not helped. So he asked for a bilateral, and thing was extremely clear that the head is dislocated posteriorly. He also ordered a CT scan, which told whatever is what. The head of the humerus is posteriorly dislocated and is hooked to the rim of the glenoid, and without this being disengaged, it cannot be reduced closed methods. So a simple X-ray like this would have told the all concerned treatment people that this requires something special, something open reduction, or certainly ask for a CT scan on the first day and then get on with it. Reconstructed motion shows that the whole of the glenoid is in front, head is sticking behind. So this is the importance of this bilateral, is how to take it and how to interpret it. It's an efficient and economical method you can do in your own clinic with 15 mm machine and save a lot of expense to the patient. They are, of course, ultimate imagers, expensive. It's not everybody has a CT and MRI in his own clinic. Not yet, at least. Eventually, it will be, but not yet. So, how it works? There we are. Oh, she had open reduction physiotherapy and she worked very well. Now, another view is very useful. It's called scapular outlet view. It is something like the bilateral, but the angles are different, and how the uh, they show the acromioclavicle joint in different varieties. Now we will just see how they are done. There are three types of acromioclavicular joints. The type 1 is almost flat and is present in about 15% of people. You can trace the line like this and it works quite well. The majority have a slightly sloped one, and that can be traced up like this. This is what we commonly see, a flattish surface. This is a flattish surface right here, and this majority of people will have it. Some people naturally have got a hook there. You can see it doesn't go straight, it comes down. So these people are prone to get irritation of this supraspinatus and cause trouble. Fortunately, the number is very low. This is because of anatomical reason. But we need to know. The scapular outlet view is most useful for this kind of work. Um, you can see that there are degenerative changes as pointed out there. You can see a large acromial spur which could cause symptoms and degeneration also. Calcification of the coracoacromial joint could also cause significant trouble and can be easily seen in a special view. No need for an extraordinary accent. This outlet view. Supraspinatus outlet view is cheap, it's simple, easily available, reproducible. All you got to know is how to position it and how to read it. MRI, CTs are good, but they are costly and they can be taken as second line of defense. Axillary view we already seen, but as I said, is alternate method. That one is very painful. Patient, even his worst hit, he can still abduct a little when supported on the side. You can and then keep the X-ray machine in this gap, keep the cassette on the top, and this way one can get the lateral also without causing much discomfort. But while lateral is much better, this is the next part. If the patient is lying down on a table, then it's difficult for him to keep it like that. So to give a saline stand to hold his arm gives a lot of relief, and then patient will allow you a good X-ray. So this is a clinical trick to give a saline stand for a support, and that works very well in favor of the patient. There we are. The saline stand is marked again. When the arm is stabbed to the chest wall and we don't want to move it for some reason or another, our patient resents it, then without disturbing, you can take Lawrence view, which is transthoracic. The sound hand is lifted up and this is shot straight away through the chest wall, and we get a picture something like this. In this position, AP is very easy, but transthoracic or something like this, that will save the day for us. When there is a plating, one can see all the possibilities there. This plain X-ray is very useful if we are going to do a plating. There is a calculation. This is osteoporotic bone, and at 5 centimeters from here, the distance between these two uh, points 1 and 2 and 3 and 4 is measured, and the thickness is calculated. If the average thickness at these 4 points is 4.3 a normal person, and this is a porotic person, so you can see it is much less. If the thickness is less, unlikely your plate will work. Certainly your standard plate will not work. With locking plate, there is a better chance of its working. But one should be aware then, and then resort to all screws on bicortical mode. If one goes with a very osteoporotic bone, unicortical, there could be a trouble. So this is a method of assessing the quality of bone in a porotic shoulder. This is quite well known that we have this medial hinge. If there is a hinge here, something like this, then the blood supply continues. And if there is no hinge, something like this, then it will lead to a poor blood supply. I'm showing you another example in which lady came up with this X-ray and she had a prompt surgery. Surgery went on very well, and which was held very securely. There was no problem whatsoever, and by end of second month she was getting extremely good results. She was very happy, and her happiness lasted for almost 7 or 8 months. Then she started getting some kind of discomfort.
I didn't catch that. Could you try again?
So when that happened, we took an X-ray, nothing much, but
I
a
didn't
month
catch
later,
that.
uh, there was issue. The head started collapsing. The head started collapsing, and in a couple of months there was total collapse, causing a lot of symptoms and required removal of the implant. There we are. So why this happened? If we revisit the first X-ray, one can see that there is no metaphyseal extension. It is blood here, and fair amount of displacement is there. More than 5 millimeters of displacement. Both are prognostic signs, and one could have been able to warn the patient that this is a likelihood of happening. Whether one would go for a primary replacement or hemi, that is discussable, but one could at least tell the patient that this is a clear possibility. This picture is quite famous. Yeah. Now, acromioclavicular joint and distal clavicle. Just we take a plain X-ray, it doesn't happen. It doesn't give any traction to the joint. So if there is an instability, we will not know. So trick is to give a heavy sandbags in both hands like this. These are 5 kilo sandbags, and patient is asked to lift them. With that, there is an automatic pull on the shoulder, and one can see the displacements if there are any. Like here, there's a heavy weight being pulling it down, and one can easily see the subluxation or dislocation of the shoulder, acromioclavicular joint. which can of course be fixed in this way, and now there are other ways also of doing it. Image intensifier, of course, we all know how to use image intensifier. These are the two most common positions. Surgeon stands on this. The image intensifier is opposite the surgeon, or it could also be at the head end, and by rotating it this way and that way, or by these two positions, one can visualize shoulder in 90 degrees of each other, which is the easy way. Sometimes we resort to clavicular wiring, but there it requires a special type of positioning. Displaced clavicles need fixation because many times this skin is threatened by this spike, and if we allow it or treat it conservatively, there is ugly deformity, there is a shortening, and shortening gives a reduced strength in that joint. If it is bilateral, it could be really bad. So for that, we take AP X-rays in two planes, a caudal tilt and a cephalic tilt. That gives us a clear idea what is happening. On digital X-ray, it is easy to find out the displacement directly. One can measure it, comes to that. I said it's more than 2 centimeters, one should offer surgery to the patient. This patient had more and he was willing for surgery. So we did that. I resort to this titanic elastic nails. C-arm on the fracture side. C-arm is free to rotate 90 degrees. Anesthetist also stays on the fracture side. Surgeon works from the opposite side uh, because the entry is from the medial end of the clavicle. Here we are. This is the fractured side, anesthetist and the technician. One can view this way and that way, so you can see that how the two views are possible. The fracture line is marked, and then the entry can be achieved through the other side. The There we are. The entry is from the medial side of the clavicle. A small drill hole is made, and the wires are passed. You can see the wire progressing across the fracture site. And all this can be recorded by just turning at every step we do this, turn the image intensifier this way and that way as I showed to you. And as the fracture stabilized there. This is day 2. Patient has absolutely no pain whatsoever. So that is a great advantage of this operation. You cannot let him drive his motorcycle the next day, but suddenly his pain is gone. We still protect him in a sling for almost 4 weeks so that the healing takes place. He's a young patient, but very recently, just before the breakdown, I did a patient who had marked displacement. Skin was very, very thin, and this portion was threatening to just come out of that. And his age was 95. It took a while for me to convince the family that this is required, but then they fortunately agreed. We were able to do it in the shortest possible time with minimum trauma. This is the amount of uh, ecchymosis that he had. At 95, everything is so brittle. He had just a fall in the house, nothing great. But this is what happened. He also had a rib fracture. So two together was causing a lot of discomfort. The moment we fixed the clavicle, the rib also got stabilized, and he was very, very comfortable with that. So nailing of clavicle with elastic titanium nail is a very good procedure. We need image intensifier. We need to know how to position your machines, and then a successful result can be taken up. So on shoulder, if you have questions, we'll take up now.